Thank you for having us here. We really appreciate being able to be a part of this. So I'm going to start with sort of the first half of the presentation that gives an overview of the project we completed and going over some of like the tasks that that our kids completed in the study. And then I'll pass it over to Hanan to get into the nitty-gritty of the functional activation patterns that we saw. All right, so here's a brief outline. First, I'm just going to start with some background of the study and an overview of what we're looking at, which is social cognition and working memory. After our aims and hypothesis, we'll move on to the fMRI methodology and give you some more details about what it was exactly that we did and the paradigms that we ran through. And then following results, we'll have a brief discussion about future research and things that we learned from this study. So a quick intro to pediatric cancer. Brain tumors are the second most common type of pediatric cancer in the US. And of course, they come with lots of issues affecting cognitive, executive, and social functioning. If anyone was at my talk at the CCBBI day, you might remember some of these slides. But so basically, within the past 40 years, the 5-year survival rate has increased dramatically from like 10% 40 years ago to almost 90% today. And so that's great news for our brain tumor survivors. But unfortunately, the treatment that it takes to treat these cancers does come with a lot of adverse late effects. So, you know, whether they had surgery, whether they had radiation, chemotherapy, or a combination of the three, this can have a lot of impact on sort of psychosocial functioning, executive functioning, things like that. So this is a, oh, sorry, was that my voice?
Yeah.
Okay, sorry.
Maybe you can mute the laptop.
No, it was totally me, because I was tracking the audio, but I think it was going to play back that. Sorry.
It's okay. So there's a number of things that can impact how kids respond to treatment. Obviously, treatment intensity is a big one. Having more radiation and more chemotherapy can impact brain surgeries themselves can be really dangerous. They can carry the risk for having a central nervous system infection. If you're placing a shunt, that can also lead to things, complications after the surgery, like seizures. And these feed into other problems that can also result from treatment. So poor neuronal connections, issues with myelination, structural damage, all of that can result from treatment. And then this leads into some of your more higher level processing things like processing speed, attention, working memory. What we're interested in most is working memory and social cognition. So those are the two things that we're focusing on for this presentation. And then this can also have an impact on day-to-day functioning, things like reading comprehension, math skills. This can really impact kids' work in school. It can result in behavioral problems at home. It can also impact their social relationships with their peers. A lot of these kids also are statistically less likely to graduate high school and move on into higher level careers as a result of treatment that they had at a really young age. So theory of mind is one thing that we looked at. And so we just have this little cartoon up. Yeah.
I picked it, so.
Yeah, there are multiple different types of theory of mind. So we've got cognitive and affective theory of mind. We're focusing on cognitive theory of mind, but this graphic kind of contrasts the differences between the two. And then also goes into some more detail about the specific brain regions that feed into cognitive theory of mind. Okay, we also looked at working memory. So I'm sure all of you are already familiar with what working memory is, but basically the way we operationalize this is the memory that is needed to sort of transform short-term and sensory memory into long-term memory through repetition and rehearsal. And then in terms of the specific types of working memory, we are looking at cognitive versus social working memory. And so we have two different fMRI paradigms that are distinct for each that we'll go into more detail later. Anything else? And then we're, in addition to social cognition, we're also looking at spatial cognition. So we have masks that we apply to our functional activation analysis that look specifically at spatial activation as well as social cognition. So the aim of this pilot study was to examine links between social cognition and working memory with the functional activation that we see in brain tumor survivors and healthy controls. And we hypothesized that relative to the controls, the brain tumor survivors will show lower accuracy on fMRI tasks that look at cognitive theory of mind, social working memory, and cognitive working memory. And we also hypothesized that this will correlate with higher levels of functional activation in task-related functional regions. And so the masks that we applied were specific to theory of mind, social regions, spatial regions, and working memory. This is just a quick overview of our demographics. We do have a really small sample size because it was a pilot study. We actually had a total of, I think, 24 that went through the study, but a lot of them didn't finish the scan or had too much motion. We couldn't use them in analysis. So we ended up with 10 brain tumor survivors and 8 healthy controls that were primarily male and had higher family income, about an average of 12 or 13 years at the scan. For the brain tumor survivors, the average age at diagnosis was 5.7. So these kids were fairly young when they were diagnosed with cancer. But the mean time since diagnosis when they arrived to their scan appointment was 7 years. So they had been several years out. And all kids were at least 2 years post-diagnosis and treatment. And then in terms of treatment type, all of the brain tumor survivors did have surgery for their treatment. An additional 4 also had radiation and 3 also had chemotherapy. Oh, yes.
Yeah, so just to clarify your hypotheses a little bit further, so like, what are you thinking is the mechanism here? Like, is it, you know, obviously like having surgery on your brain is a really traumatic thing, and then like that in and of itself is like maybe quantum changes, or?
Yeah, so we think that the impact of a brain tumor itself can be harsh enough. The treatment can also add to that impact. And so because of the small sample size, we weren't really able to parse out what effect the different treatments had on the kids. So this is really just like what's the overall impact of having a brain tumor and the treatment that follows diagnosis.
And the reason why we would expect higher levels of functional activation is due to the neurotoxicity of the treatment. It causes impairments in the brain. So we would expect to see over-recruitment in different functional areas during specific tasks.
Over-recruitment.
Over-recruitment of brain areas to perform the same task as our healthy controls.
And the over-recruitment is it a compensation for like being like performing worse? Or?
Yeah, it's like a compensatory mechanism to perform at the same level as controls.
Yeah, that's a good question.
Thanks.
And then just a quick overview of the different types of tumors that our kids had and the tumor locations. Most of them were supratentorial. The rest were infratentorial except for one in the midbrain tectal region.
I'm sorry, I have a question too.
Yes.
You may have mentioned this, but are all of these patients in remission, or is there any ongoing cancer for any of these participants?
I'm pretty sure that at the time of participation that they were all in remission.
Okay.
It is possible that following participation that they had to have more treatment later on, but at the time of participation they were in remission. Yeah.
If we have an incidental finding on our scans, we won't be including them in our analysis.
I see. Okay.
Yeah.
All right, so now I'm going to walk you through the paradigms that we had these kids complete. They played 3 games, and I'll show you how they work. So first we have is it okay if I go over? Okay. We have the game called Jack and Jill. As you can see, the graphics are amazing. We have 2 people here, Jill and Jack, and there are 3 frames to each trial. In the first frame, Jack is choosing either a blue or a red hat to place the ball into, and Jill is either watching him do this or she's not in the room. In the second frame, he either changes his mind and puts in the other hat or drops in the hat that he's going to drop it in. And again, Jill can either be in the room or not in the room. And in the third frame, Jill's thinking that the ball might be in a particular hat. And the kid basically just has to respond yes or no with a 2-button box, whether her thinking is correct for what she saw, not where the ball actually is. So this is something that kids that have been treated for cancer might have a more difficult time with. Theory of mind is something that typically develops at a younger age, but if they were like diagnosed and treated at a young age, then that could impact their development of these skills.
And there are 4 different trials for this task paradigm. This one that you saw is specifically the cognitive theory of mind trial, where the ball was switched by Jack and not witnessed by Jill.
Yep.
So if the participant chooses correctly based on what Jill saw, not based on what they saw, then they're employing cognitive theory of mind to make the correct choice.
All right, and then we also have the people game. All 3 games are actually experimental tasks, and the people and places game are tasks that were developed by our PI, Dr. Hoskinson. So I'll walk you through how we actually train kids on the task to sort of give you an idea of what it looks like. So we tell them we want you to meet.
This is going to be interactive.
Yes, it's going to be interactive, so pay attention because we're going to ask you some questions. All right, we've got David. Okay, remember David. We have Anna. We also have Rachel. And we have Mike. And we're going to learn about their relationships to each other. So first we have Anna and Mike and their brother and sister. Usually this is the time where we ask the child, do you have a brother or sister? And they're like, yeah. And we're like, do you always get along? And they're like, no. And that's what we tell them that Anna and Mike are like. They are siblings that fight pretty frequently. So this is a negative valence scenario in the task. And we have David and Anna who are best friends. And they're like, yeah, I've got a best friend. We ask them, do you get along? And they said, yeah. And we tell them that David and Anna hang out all the time. Then we've got David and Mike who are enemies. And so most kids understand that means that they get into fights. And then we have Rachel and Mike who are boyfriend and girlfriend. So they are practically married. They're in love. Okay, remember all that? We're going to think about how happy these characters would be about good and bad stuff that happens to them. So for example, Mike won the lottery. Who is first most happy that Mike won the lottery?
Jill. Is it Jill?
No. That was Jack and Jill.
So if Mike won the lottery, who's first most happy? Yeah.
Yeah.
So we're going to have Mike be first most happy. Who is second most happy?
Rachel
Nice
and his
job.
girlfriend, yep.
Third? Yep. Anna. And then last? Yeah.
Yeah.
David. Perfect.
Exactly.
So this is a negative valence scenario where Mike got a sunburn. Is that a good or a bad thing?
That's bad.
Yeah. Some kids don't know that, so we have to explain that.
Who's the first most happy that Mike got a sunburn?
David.
David, that's right. Who's second most happy?
Nice job.
Third most happy? Yep. Fourth most happy?
You have great working memory.
All right, so here's what the paradigm looks like and what they actually see in the scanner. So I'll walk you through this. They see anywhere from 1 to 4 characters on the screen at a time for a given trial, and we tell them to only think about those characters and their relationships to each other for that question.
And the more characters are, the harder that trial is.
Yeah. Yep. So for example, Mike won the lottery. Oh, question, yes.
So in your hypothesis, is this your like social working memory test?
Yes,
then?
exactly.
So that's a term I hadn't heard before, like hearing talk about previously. I'm curious, is that defined as like a separate category working memory, like where someone could be really good at other working memory tasks, but at social working memory they can be poor, or do they generally correlate?
Well, the idea here is to tease out the differences to see if there are differences between social and cognitive working memory.
Okay.
That is an interesting question, though. I don't know exactly what the literature says. I feel like if someone's generally good at one type of working memory, that they would be better at others, but it's possible to have some differences. Like,
There's more features to remember.
yeah, there's more to remember. Yeah.
It's a lot of working
And
memory capacity.
So another aspect of the study that we aren't describing today is the portion where another lab goes into schools and they'll look at environmental and social function of these kids post-treatment, where they look at like peer victimization, social ostracization, reciprocal friendships. So they are getting that social area, and then we're looking to contrast the scan data related to social function and then their social function in the environment.
Mhm.
In each group of So I'm assuming there's more than just these 4. There's more than 4 characters.
There's only the 4.
There's only 4 characters, yeah.
And their relationships are the same.
For this game, yeah, this is all that you need to know for this game. And then the cognitive working memory task, which I'll also go into, has the same characters, but we're learning about where they live spatially instead.
And so, like, if the, you know, so you presented this information once, then, you know, theoretically, if you, like, forget that David and Mike are enemies, then you're going to forget that for the entire task.
Yeah, and so that's why we administer a practice trial outside of the scanner first. And that's done through ePrime, and they do have to maintain a certain level of accuracy before it lets them finish the practice trial.
Yeah, they have to get at
To make
least
sure they
75% correct on the
Of
practice.
these orderings.
Yes, and we also have a pre-test check. This is like a paper-based measure where we ask them to point to the people and we're like, who's the brother and sister? Who are the enemies? Do they get along? And so they have to complete that before they go into ePrime and do the practice trial.
So there's a little more training.
Mhm.
Yeah.
Okay.
I think you're going to get into this, so maybe this is a segue question.
Sure.
But I'm curious how the participants are responding. Like, is it you show them 2 images and they say which one? Do they have to remember the names?
Yeah,
That is next.
That's
Yes.
Because like when you were asking your questions, I was like, shoot, I can point to the person, but I don't know what the name was.
Yeah.
Yeah, so this is an example of exactly what they would see in the scanner. So first they see anywhere from 1 to 4 characters, and we remind them to only think about those characters and their relationships to each other. The next thing they see in the scanner is a good or a bad event, like Mike won the lottery. Then they see a thinking cross for a few seconds, and they're using a 2-button box in the scanner where 1 button is yes and the second button is no. And then the question arrives, is Mike the first most happy? So that's where they have to decide, is this a yes or a no? And this switches up with like, is Mike third, or is David third most happy? Is Anna second most happy? So they switch up the order and you have to figure out whether it's accurate or not for that trial. So like, So for this one, we're only thinking about David and Mike. So they're not gonna ask you about Anna, but if they say, but you have to keep in mind where David is in relation to Mike in terms of how they would feel about a situation. Does that make sense? It's not an easy task. It's really not easy.
So is Mike first most happy? Yeah.
Yeah, exactly. All right, any other questions about the people game before we move on to the next one? Okay.
So it feels like there's like 2 pieces of memory here. I'm not
Yeah.
a memory user, so
Yeah. So
like there's like the memory of like the main relationships, and then there's the memory of like the delay in between the question and the like who is first most happy. I don't know how long that delay is.
yes. So we have that delay in there because these are event-related designs
Yeah.
with intertrial jitters, so
I
that
see.
when we map our functional analysis to it, we have enough jitter time in between.
Mhm, and that's only 2.5 seconds.
Yeah.
It's not really like a-
It's not too long. So it's not like an end-back task where you have to like keep things in mind for a long time. There is definitely a cognitive aspect to this, I think, just having to remember like the order of things. But the social valence is what we're really interested in this one. And then with the cognitive working math task, which I'll show you next, it's more spatial based instead of relationship based.
Okay.
Yeah. So this is the places game. It has the same characters as in the people game, but now we're going to learn where they live. So there's only 1 of 2 places they can live, out in the country or the village/town, and there's only 1 road that connects the 2. David lives all the way out in the country, pretty far from the village. You're going to be quizzed again, by the way. So. Anna also lives in the country, not too far from the village. Mike lives in the village, a little closer to the country. And Rachel lives all the way out in the village, pretty far from the country. So they go through another pre-test check where we ask them who lives in the country, who lives in the village. We ask them, is Mike closer to Anna or Rachel? Things like that to make sure that they truly understand before they go into the practice trial. All right, and then we show them the ePrime practice. They're going to be doing different activities in their town. For example, playing hide and seek at Mike's house. Okay, who arrives first?
That's close.
Trick question, it's gotta be Mike, because it's his house.
Interrupting, like who's first most happy?
Yeah.
You would think like I almost don't include Mike.
Yeah.
That could be a problem.
I know.
Yeah.
It's
I will say the
Right.
functional results indicate that we should consider potentially modifying the test.
I see.
A little bit. That's okay.
All right, do you guys know who gets their second?
Rachel.
Who gets their third? And who gets their fourth? Yeah. And sometimes kids will ask, well, why don't Mike and Anna live together if they're brother and sister? Tell them they're grown. They have their own houses now. They're playing hide and seek as adults. So this is the paradigm. It is really similar to the people game. It's actually the same number of seconds and everything. And so this is what the task looks like. They'll once again see anywhere from 1 to 4 characters on the screen. So for this example, we just have David and Mike. They're playing hide and seek at Mike's house. This is usually when the kids call us out and they say, but they're enemies. Why are they playing hide and seek? And we have to tell them to disregard the people game for this task. Thinking time, and then does Mike arrive first? So this is where they would select their response. And same as the people game, they do a practice trial through E prime, have to get 75% correct, and then they move on to the scanner. Any more questions about the places game?
Okay. Oh, wait, yeah. Yes. Do you kind of balance these tasks? Like, do they ever do the places before people?
No, they always do Jack and Jill, people, and places.
Yeah.
Which is, I think about that sometimes because I feel like it would make a difference, like if we counteracted them. And also, this is just my opinion, but I feel like the places game is a little easier than the people game.
Because I would imagine you get less of that over effect with the people game. Like, oh, they live far apart. Why are they friends? Like, I don't.
Yeah.
Whereas, like, I do understand the relationship kind of being interfering with this.
Mhm.
Yeah.
Stuff.
Yeah.
But, yeah.
Also glad that kids are catching on with the complexity of relationships.
We have a surprising amount of kids learn this really fast. So
And there's some that just never do.
yeah, there's some that just never learn it. So
Yeah, wide variety. All right, so now I'm going to dive into the task accuracy and what we found between groups. For Jack and Jill, we didn't really see a lot of significant differences in terms of accuracy. One thing that we did find was a difference in response time average ignoring omissions. So this is excluding any questions where a kid did not respond at all. And so just looking at the ones where they did respond, the brain tumors did have a larger response time or were slower than the healthy controls. And we didn't have really enough power for significance on most of these, but we do have Cohen's d size effects. And so this was a moderate effect size between the two groups. We get more out of people and places. So what we evaluated was both total accuracy on the task between groups, and then also the higher load or trials, or the ones where they had 3 or 4 people to think about. Those are more difficult for them. And so consistently across people and places, we saw that the brain tumor survivors did perform more poorly than healthy controls, both in total accuracy and the higher load questions, with moderate to large effect sizes. All right, we also looked at positive and negative valence. So this is your, Mike winning the lottery versus Mike falling off his bike. And we found that, again, the brain tumor survivors did perform more poorly generally than the healthy controls in both conditions. We also noticed that the positive valence situations were a bit easier for both groups than the negative valence questions. And we have moderate effect sizes there as well. Okay. So now Hanan's going to take over and he's going to dive into the more methodology of specifically what we did with our analysis. Real quick, how familiar are you guys with FSLs? Do you guys use FSL or do you use more SPM and stuff like that? No?
We're mixed.
Mixed? Okay.
So we use predominantly FSL for all of our processing for our functional tasks. These are our fMRI parameters. So I'm going to be using their MP range to pull their structural brain, which I'm sure you guys are familiar with. I'll walk you through it anyway.
I just about the bar graphs before, because of the low end, it's hard to do the statistics. Just subjectively though, does it look like you have outliers that could be skewing the graphs, or is it uniform?
Yeah. So we excluded kids that did not respond at all. But I think There were a couple of outliers, just looking at the data of kids that were really just doing pretty bad and maybe getting like 50% of it correct. But for the most part, I feel like kids either got all of them correct or just missed a few here and there. And that was most of our sample. Yeah. Yes.
So what's the quantitative negative balance in place?
So the
Oh, yeah.
positive negative valence in the place task is related to the event that's going on at that individual's house. So for example, like before we run through, we have this list of activities like
So a fun
losing
like,
your,
oh, go ahead.
like
No, it has to be a group activity though.
yeah.
So like a positive group activity would be like, we're all having a party at Anna's house. But then a negative group activity could be like, we all have to take the garbage out at David's house.
Fun group
activity. A lot of garbage.
Yeah, like cleaning the barn. We ask them like and then we also get their individual responses for like, is this a fun or not fun activity?
Yeah, we do that with a pre-test check. Some kids like to clean barns. And I don't know, some kids enjoy folding laundry and washing dishes, and other kids don't like going to parties. So we get a measure of this before the task on that paper-based assessment to make sure we can match that to the valence that they are like perceiving during the scan.
That's a good question. All right, so our MP range has a slice thickness of 1 millimeter with 1950 milliseconds TR and a 4.44 millisecond TE with a 12-degree flip angle. And then all of our functional tasks have the same 3 millimeter slice thickness, 2000 millisecond repetition time, and then 28 millisecond echo time with 70 degrees flip angle. All of our images were acquired with interleave slice acquisition and ACPC alignment. So the first thing that we do is, since all of our kids underwent resective surgery, I want to make sure that instead of mapping their functional scan to a template brain, their brain will not be like a template scan. I want to take their MP range and extract their structural data. So this is what that next step is I'm using their mprange.nii.gz, so that's just a zipped Nifty file, and I'm converting it into that mprange underscore brain, which I'll reference a little bit later during pre-processing. So now I'm going to go to the feet fMRI analysis, and I'm going to select the 4D data that I'm going to use. So we have our three different functional tasks here. There's Jack and Jill, people, and places. And I'm going to make a feet file, which is on the left for each of those tasks. So the next step is choosing our motion correcting and warping parameters, and that's what these settings are. And then I'm going to go to the registration of the image. So instead of using the standard space, I want FSL to attempt to map their functional data to their main structural image first. So that's when I'm going to select their individual MP range. And then if it's too wiggly and the kid moves too much, it will then reference the standard space. That's a standard template brain. Is there any questions? Right.
So you're saying that if they move too much, then everything goes to the template brain, and otherwise it's native space?
Yeah. Yeah. So, and we, like the output will tell us if it ran how we would want to or not. So now oh yeah.
Why if they move the loss?
So we have such a small N that we want to try to include as many people as possible. For this one, we didn't have anyone registered to the standard space. They all successfully registered to their own brain. There were 4 people that didn't, and they just had to be excluded because it was just way too much motion during the functional responding, so we couldn't even use their functional data. So now I'm going to run the first level statistics. That's when I'm selecting each of their individual feet directories. And then I'm going to go to the full model setup, which I'm sure you guys are familiar with, hopefully. So we have a bunch of different onset files that we create manually, which are the ones down here in this text file in the bottom left. And that has the time that they responded, the jitter time, and then was it accurate or not accurate, and that's a 1 or a 0. If it's in a correct text file, there are going to be 1s. If it's in an incorrect text file, there are going to be 0s. Then we make EVs related to each of these onset files. So for Jack and Jill specifically, we have 8 different onset files. We have 8 different EVs. And then for people and places, we have a few more. So this is what our contrast pattern looks like for our Jack and Jill task. I wanted to separate the main effects so that I can look at how they individually contribute, like the individual contribution of the trial and then the task accuracy. That's why I split up whether or not it was like the ball was left in place and Jill witnessed that, or if the ball was switched and she witnessed that, which are the first 2 here. That's main effect left witness correct, and then main effect switch witness correct. The trial that we are most interested in, which is our theory of mind trial, is number 5. So that's our main effect of Jack switching the ball, Jill not witnessing it, and then the participant still gets it correct. So that's our theory of mind trial. I included the 4 ones on the bottom because I'll probably be running the analysis on the main effects of switching and then witnessing, and then their interaction effects a little bit later on.
Quick question, you may mention this. How many trials do you have in each of those 4 different Jack and Jill conditions?
4 of each, so 16 total.
This is our contrast pattern for people and places. This is just people up here. So just like the last one, I separated it out so that we're looking at the main effects to see the individual contribution of each of the conditions. So we have level 3 and then level 4, which are our hardest levels. So that's when you see 3 children on the screen or 4 children on the screen, and they have to pick out the order from there. And I took the positive and negative valence, and this time I only did when they responded correctly. Because if they responded correctly, then they were not using like social cognition the way that I had anticipated them to. For the images I'm going to show you, I compared, or I looked at the main effect of valence, that's number 6. So I wanted to look at level 3 and 4 together relative to whether or not the event that happened was positive or negative, so that I was including both of the levels in my sample. For this step, I used uncorrected thresholding at a p-value of 0.1 so that I wasn't eliminating all of my data, and I'll later move it to p is less than 0.05. So now I'm going to start my higher level statistics. This is a screen capture of the Jack and Jill one. We had 18 participants successfully complete scans and successfully have fully processed scans for 18 of them, and then for people and places we had 14 in each of those. And then I'm going to go to their full model setup again. So on the right, I am designating their inputs, all of them, as ones that I'm looking at, and then for the intercept, I want to make them all positive. And then the 1 and -1 in the group EV is related to whether or not the participant was a pediatric brain tumor survivor if they're a healthy control. Pediatric brain tumor survivors are 1s and healthy controls are -1s, which is why on the left side in the contrast tab, I have my positive intercept, my negative intercept, and then the main effects of group 1, which are my brain tumors, and then the main effect of group 2, which are my healthy controls. From there, now I'm going to change the uncorrected thresholding to p is less than 0.05, and we're going to run that, and then we used FSLIs to view our data. Do you guys have any questions, comments, anything I just talked about? All right, so we used the regions designated by meta-analytic maps from NeuroSynth for doing our analysis. So since we use visual tasks, we'll see activation in the visual areas of the brain, and I wanted to eliminate that by applying theory of mind mask, spatial mask, social mask, and then a working memory mask onto my data. And I looked at it in all 3 of those, the spatial, social, and working memory for people and places, and then theory of mind for Jack and Jill. So this is a really brief picture of what the theory of mind mask would look like. So we'll only see activation in these areas. So this is theory of mind activation during Jack and Jill. So from this, we can see that our pediatric brain tumors are activation in yellow, and it is very small, which is why I circled them. And then our healthy controls are activation in green. And that's where they showed increased activation compared to the other group. So in the theory of mind trial, we saw increased activation for pediatric brain tumor survivors in the broadly like social cognitive areas of the brain relative to our healthy controls.
This is whole brain, or no, it's a mask. Is it corrected for multiple comparisons?
Yeah.
Yeah.
I thought you guys are analyzing data just within a group, so the comparison was just one time per t-test for each group, not comparing to, right?
So, sorry, could you repeat that?
So I thought the group level contrast was just mainly that of each group, not the difference between two.
Yeah, so I put both of them onto this one. So
Oh,
here where I talked about the C3, so contrast 3 and contrast 4, both of those are on that image. The contrast 3 is the colors I used are yellow and blue. Yellow is increased activation, blue is decreased activation. We didn't see any areas with decreased activation. And then C4, which is our healthy control group, our increased levels of activation is going to be in green and decreased levels of activation is in brown, but we didn't see any areas with decreased levels of activation. So I put both of those onto the, like after I masked them, I added them together and then looked at the differential activation. Did you have a question about that? Okay. And then this is my social region mask, which is the social associated areas. And this is a social activation during people, which is one of our more robust findings. So we saw a lot of activation in the bilateral frontal orbital cortex for pediatric brain tumor survivors, in addition to our like temporal gyri and then angular gyri, which is what we were expecting to see is more increased activation for our brain tumor survivors compared to our healthy controls, potentially due to over-recruitment. And then in our healthy controls, we saw some activation in the subcallosal cortex and then right frontal pole. This is social activation during places, and there are some areas of activation, but they're not super different from our healthy controls, which is what we were expecting to see. People is our social cognition task, which is why we see so much more activation during there. So it does seem like it's working appropriately to look at social function and social cognition. Places does not, which is what we had expected. And then I'm looking at the spatial regions using the mask. This is spatial activation during people. They're also not very different, which is what I had expected to see because the people task is not looking for spatial cognition. And then it turns out that the spatial activation during places was not as robust as I had expected. So we're not completely sure if that is like as sensitive as we'd like it to be towards spatial cognition. However, when I applied the working memory regions mask to it, we did see some activation in people. There was some activation in the cerebellar areas right there for our pediatric brain tumor survivors. And then also in places, we saw activation in working memory. The main difference is that our healthy controls were kind of pulling towards their frontotemporal regions, which is something that we thought was really interesting. So do you guys have any questions right now?
So you said the people, the trauma patients were recruiting more cerebellum
Versus our healthy. Yeah.
Did you have a question?
Oh yeah, you know, just sorry for the nitty gritty. What multiple, like what corrections did you use?
Yeah, we used FDR as P is less than 0.05. Okay. So it's a Z of 2.3. Sorry.
So like just for compare, FDR is the one where you'd expect 5% of all the voxels to be activated. Is this more than 5%?
Yeah.
The voxels in the mouse? Like what percent is it?
I don't remember. I'm sorry.
Also, you said this was native space, right?
This is a group composite of the activation. So it is registering their native space to now a template brain because it's taking all of their native spaces together since like our healthy controls and our brain tumors, we mapped it first to their brains, and then we have to warp it to a standard brain.
So the analysis is done on the native and then it gets transformed?
Yeah.
Okay. And one more question,
Mhm.
sorry. So you said that this is a difference map, but you made basically a separate activation map for the brain tumor and for the healthy controls, and then in FSLIs you did the difference?
In FSLIs, I added both TSTAT3 and TSTAT4. So TSTAT3 is where pediatric brain tumor survivors are showing increased activation relative to healthy controls, and then TSTAT4 is where healthy controls are showing increased activation compared to pediatric brain tumor survivors. So I viewed both of those at the same time, and then the increased activation for brain tumors is labeled as yellow, while increased activation for healthy controls comparatively is labeled as green. They do have their counterparts of like decreased levels of activation for areas, yellow contrasted with blue, and then green contrasted with copper or brown. But we didn't see significant areas of decreased activation for either of our groups. So our takeaway is that healthy controls consistently outperformed pediatric brain tumor survivors on measures of cognitive theory of mind, social working memory, and then cognitive and spatial working memory. People in places in particular were able to detect group differences with moderate effect sizes, and this poor performance might be partially explained by not only the impact of the tumor, but also the treatment on brain systems that support theory of mind and white matter, or working memory. Sorry, WM. And a lot of that might be due to the neurotoxicity of the treatment on the brain. And then our differential activation during functional tasks, specifically Jack and Jill, our pediatric brain tumor survivors, did have greater activation in the social cognitive regions in the theory of mind map, which is what we had expected. So we do see our pediatric brain tumor survivors over-recruiting compared to our healthy controls. While in people and places, it's a little bit harder since I use that main effective valence. I'm not able to parse apart like the levels in itself because I combine the levels and then contrasted valence. So I think it would be easier to gauge. I can take the main effects that I have and then do them separately, so I can split out the main effects of each one, which is what I'm hoping to do a little bit later. And social area differences in people is relatively robust, so our task looks like it's functioning properly. The working memory and spatial area differences in places is a little bit not what we had expected. So I think in future research, we should look at kind of refining our task a little bit more. So we do have a smaller N in the study since it was a pilot study. And we're looking to attempt to confirm these results in a larger sample size with more power. And then a larger sample size could kind of help us tease out the differences of sex and then age at diagnosis, tumor type and tumor location. Since you, like we talked about having it registered to native space and then the larger, warping it to a standard template, all of the, like the resective surgery does have an impact on their brain, and we want to control for the areas that were resected, and we can't do that in the smaller sample, but that is something that we want to do in a larger sample. And then types of tumors can be more severe than other ones, so we also want to look at tumor severity as a covariate for activation. So we do want to control for areas of resection in the future, and then the difference between the cerebellar activation in our pediatric brain tumor survivors and the frontotemporal regions in our healthy controls is something that we really want to investigate too, because that is something that was very interesting. We would like to thank the St. Baldrick's Foundation and Nationwide Children's Hospital for their funding. And then we also want to thank you guys at the CCPPI for letting us scan with you. And then the research participants and their families. It does take a lot for them to do these study visits with us, and we really do appreciate it. And then our supervisors. If you guys have any questions. Yeah.
Yeah. So this is cool stuff. I'm curious if, I mean, yeah, I'm wondering if like the magnitude of the activation during these tasks in either of these like social or working memory regions is like correlated with their task performance, and if there's some kind of if like pooling activity from those regions like correlates with that, and then beyond just like trying to test for these group level contrasts, you can make claims about individual differences.
Yeah. So our next step in terms of our analysis is kind of parsing apart the different levels of main effects. So after we do that is contrasting it with the task accuracy of each level and then each valence to kind of look at if there are any relationships there. And we would take the beta values from the functional data and contrast it with that.
I guess too, something that I was like surprised when you were presenting your behavioral work. Do you expect the differences that you saw in valence in terms of performance for the social task, and what or I guess what's the benefit of separating those groups instead of kind of smashing them together and getting more power from your estimates that way?
By groups, do you mean brain tumor versus healthy controls?
Like
or
groups, I
the,
mean the valence conditions.
the positive and negative?
Yeah.
That's a good question. I think I haven't done enough literature review. I think personally I thought that maybe negative valence would be more significant because I feel like people attach more emotion to that.
So
But
like in our socio and environmental studies, we do find that our brain tumor survivors are having a more negative social experience post-treatment for their trauma and their tumor. So that is kind of represented here a little bit, where you do see like better or like responding in the positive valence than you do see in the negative valence, which is typical for what we would expect, but you do see our brain tumor group performing more poorly compared to our healthy group, which could be related to like their socialization post-treatment.
which I think just personally I would have thought that they would have performed better negative because they're more sensitive to that given their experiences. So it's not what I expected to saw, but I also like I don't know what the literature has to say about it exactly.
There also seems to be kind of two sources of valence. There's like the valence from the situation, right, the sunburn, or there's also the valence of the relationship.
Yeah.
So I don't know if if you, I mean, at this point for the task accuracy, maybe you can get estimates, but I don't know for brain activity if you could.
I think that would be really interesting to look at. Specifically thinking about the amount of trials we have for each condition. I don't know if we would be able to split it up further.
Yeah.
We should probably transition our functional task paradigms to like block design with multiple runs, because right now we only have one run for each one. So that is something that we should consider looking at in the future.
And the valence, this is only salient because of the example that you guys gave of the lottery versus the sunburn, but like, the lottery seems a lot better than the sunburn.
Yeah.
Right? Or like then the sunburn is negative.
Yeah, we
And
have.
is there control for the magnitude of the valence?
We did not control for the magnitude of the valence, but there are a lot more examples like breaking your leg or like losing your favorite hat. So it does range between like how bad, like a little bad to very bad. So that is something that is also important to look at. And it's kind of harder to gauge because that's so subjective for each person as to like what is the worst thing to happen to me. Yeah, it's a very subjective experience.
Yeah, if you really love your hats.
Yeah, it'd be worse than breaking a leg. Are there any other questions?
What is your planned sample size?
Our planned sample size, so the group we partner with is the Venata Lab, and they are looking at submitting a grant for funding to recruit 100 families, and that's going to be 50 in each group.
And then your plan is like already similar to the behavioral effects you expected to see, or like?
It is similar.
Because these are pretty big number, like, you know. they're
Yeah.
decently sized effects.
Yeah, so we are hoping, like with a larger sample, to kind of look at more covariates related to these effects. These are similar to what we would have expected.
My other question was, so to me it's interesting that, because I'm guessing that your subjects don't have tumors in the exact same location, that you're seeing deficits across many domains. So like, is surgery just that traumatic, or is treatment that traumatic to whole brain? Or are you looking at like high enough level networks or most robust giant networks that are crossing areas that you would see?
Yeah, a
differences?
surprising amount depends on the age at which the participant underwent treatment for it, due to like cortical reorganization for different functional areas. And then we do see, like classically in literature, that children who've received trauma at a younger age have better outcomes than children who've received trauma at older ages.
So that because their brain can make up for the
Yeah.
much better than an adult. So like in an adult, then I'm guessing that you see much more like localized changes than across brain. Like if you're testing everybody on theory of mind, but someone had like a visual cortex.
I hate to interrupt, but we have an official guy in the room as of right now.
Okay. Sorry.
We'll clean up. Oh,
Sorry we went over. I apologize.
No, that's okay. This was a great discussion. Thanks for all of this interesting data. Excited to see where the project goes.
Yeah, thank you for having us.
So, if you guys wouldn't mind just having a couple extra hands, just take this and put it immediately into the lobby. That would be amazing.
Okay.
Yeah. And please take some to go.
Yeah.